system. Let's go back to the heart one more time, because we didn't talk a lot about the coronary arteries, and so we'll talk about the coronary arteries today. When you look at the heart, there are only a couple of, well, more than a couple. There are a few major vessels here that I want you to be able to appreciate. This is the aorta. If you remember, the aorta comes out of the left ventricle. There's a valvular system here for the heart that prevents blood from backflowing into the chamber of the left ventricle. But as blood passes through the aorta, if you're following the arrow there, and you can see the arrow, right? Yeah. As you're following the arrow there, as blood flows out of the aorta, when the heart then relaxes, a little bit of blood flow actually comes back toward the heart. Now, the valves, by design, will shut off and prevent the blood from filling up the left ventricle again, but it's at that point where the heart relaxes that the coronary sinus here fills up and blood is actually passed into the coronary arteries. And so there are some big arteries of importance that you need to know. You need to know the left main coronary artery. Left main coronary artery. Now look at what the left main coronary artery does. It supplies blood to the left ventricle of the heart. What's the most important chamber of the heart? I'm sorry? The left ventricle. Left ventricle. Why? The left ventricle has to pump blood to the entire body. If you damage the left ventricle, then you are in a bit of trouble. The left ventricle is supplied by the left anterior descending artery. That's this one. Comes off of the left main artery. So does the left circumflex artery, which supplies blood to the posterior aspect of the heart as well. Now, the heart beats. You know where the heart sits at in the chest? I hope you're saying yes. Okay. So the heart beats. It's really the front part of the heart that's beating, the front part of the left atrium, because the back of the heart is fixed. It's up next to the chest wall. So it's really the front of the heart that's beating. And so when the ventricle contracts, it's the pumping motion of the anterior portion of the heart that's responsible for pushing out the majority of the blood. So the left anterior descending artery is important because it supplies blood to the front of the heart, and the left circumflex artery, coronary artery, is important because it goes to the back of the heart, but not as important as the left anterior descending artery, because the back of the heart doesn't have to squeeze a lot. If you had a heart attack in the back of your heart, not that having a heart attack is a good thing, but if you're going to have one, have it in the posterior wall of the heart because it's not involved in the pumping. The pumping's in the front. Okay, so you can have a heart attack in the back. It'll scar down. You'll have scar tissue there. But if the front of the heart is pumping, you actually haven't lost any cardiac function. If you have a heart attack in the front, especially on the left side of the front, then you're in trouble because that's the left anterior portion of the heart. Left anterior descending heart supplies blood. Now, if you block the left main coronary artery, what branches off the left main coronary artery? Hint, the left anterior descending artery and the left circumflex artery. So all of the left ventricle is supplied by this left main artery, by its branches, the left anterior and the left circumflex. So major artery, left main. If you have left main disease, if you have a left main obstruction, that's called a widowmaker. That's a heart attack that you don't get over. You typically die if you have left main disease. That artery blocks off. It cuts off circulation to the left ventricle of the heart. You have a massive heart attack. You typically don't recover from that. If you do, you're a cardiac cripple. So very important blood vessel there, left anterior descending, left circumflex, but also, most importantly, the left main coronary artery. Now, the other artery that's important to recognize is the right coronary artery. Right coronary artery. You see that here. Right coronary artery. It supplies, obviously, the right side of the heart, the right ventricle. Branches, diagonal branches come off and supply the right atrium as well. And then there's the circumflex portion of this that will supply posterior wall of the heart. Now, you may have heard the term right dominant, left dominant as far as coronary arteries. In some individuals, the left circumflex provides most of the circulation to the posterior aspect of the heart. In some people, the right coronary artery supplies most of the circulation to the posterior aspect of the heart. That's neither here nor there. Those are the vessels that you need to be able to know in coronary arteries. You need to be able to identify those on a lab examination. You need to understand the importance of left anterior descending artery, left main, left circumflex, right circumflex. Is it more significant to have a heart attack in the left anterior descending artery, the left circumflex artery, or the right circumflex artery? I'm sorry? Say again? What's the worst vessel to get blocked? Left anterior descending artery, the right circumflex, or the left circumflex? Left anterior descending artery. Why? It supplies the left ventricle. Simple as that. Big muscle demands a significant amount of oxygen supply, so you got to have blood there. Now, is it a worse heart attack if you have a heart attack that's a result of an obstruction of the left main coronary artery? Yes, that's worse than any of the above I just listed, okay? So keep that in mind. Those are the basics of the coronary arteries. Now, we could spend a year talking about coronary arteries because they're little diagonal branches. If you get an obstruction someplace, new branches. You may hear this term before. The doctor said I grew new blood vessels. Well, you didn't really grow new blood vessels, but if you look at the circulatory system of the coronary arteries, if you get an obstruction distally in the left anterior descending artery, a distal obstruction here, what happens? If it happens gradually over time, the other blood vessels that are here will start to hypertrophy and enlarge, and they will start delivering more blood to other parts of the heart, to the left side of the heart, because this vessel is becoming obstructive. So some people don't have to undergo major cardiac surgery because tributaries or branches enlarged as a result of slowly progressive coronary artery disease, and they essentially grew a larger vessel. The vessel was already there, so it's not like it sprouted new buds and started growing. It was already there, but because there was an increased demand and it happened over a gradual period of time, the blood vessel had a chance, the body had a chance to compensate and develop that blood vessel into a larger vessel. Now, that's only if it happens gradually over time. If you have an acute heart attack, you don't have time to grow new vessels. You have a heart attack and you die, or you have significant myocardial injury. Okay, so just another little concept I want to throw at you there. So blood supply to the heart. Heart works continuously. Cardiac muscle requires reliable source of oxygen and nutrients. Great volumes of blood have to pass from the chambers of the heart to the myocardium. Myocardium needs its own separate blood supply. That's what the coronary circulation supplies blood to the muscle tissue of the heart. Maximum exertion. Look at my hand, pink on the inside. Squeeze it real hard. It becomes blanch. Whites out because it gets a little bit ischemic. Now I'm forcing that because I'm straining my hand. Okay, but I keep doing this over a period of time. My hand gets kind of sore. Why? Because there's a huge oxygen demand. I'm straining those muscles in my hand, and I'm increasing the oxygen demand. Think about your heart the same way. As the demand increases on the heart, the oxygen demand is greater. The greater you squeeze it, the more force, the more rapid your heart rate is, the more pressure it has to work against. In the case of hypertension, it takes an enormous amount of force to go for the heart to press against someone who has hypertension. So that strains the myocardium, that increases the oxygen demand. If the coronary arteries aren't supplying enough blood supply, it can lead to major cardiac problems. These are the vessels. This is from your textbook. Again, the vessels that we've talked about before. Left coronary artery, I refer to it as the left main coronary artery. The anterior intraventricular artery, another term for left anterior descending artery. The right coronary artery, as you can see over to the side, there is the circumflex artery that's been transected here, but typically would circulate around to the posterior aspect of the heart. These vessels are shown in this gross anatomical picture as well. This shows you a posterior view of the heart, and you can see where the circumflex arteries actually will come around and supply blood supply to the posterior aspect of the heart. Coronary arteries originate at the base of the ascending aorta, and I've already talked about the pressure that's involved there. Each time the left ventricle contracts, it forces blood out the aorta. The arrival of additional blood elevates the pressure, stretches the elastic wall. Then when the left ventricle relaxes, blood no longer then flows through the aorta, out of the aorta. The pressure declines. The walls of the aorta will then recoil. The recoil, or elastic rebound as it's called, will cause the aortic sinuses then to fill with blood. When the aortic sinuses fill, that's when the coronary arteries receive blood supply. So it's at diastole that the heart will, that the coronary arteries will fill with blood. So that's an important concept to remember. It's when the heart is relaxing that you'll see the coronary arteries begin to fill with blood. That's important as well, because if you think about the myocardium contracting and squeezing, it's actually an ischemic effect that happens naturally when the heart's squeezing, because the heart is contracting tightly. So those vessels are going to contract with it, and because of that, the coronary arteries can't fill. It's only when the heart relaxes that those coronary arteries are allowed to take up blood. Right coronary artery follows the coronary sulcus around the heart, supplies the right atrium, portions of both ventricles, and portions of the conducting system of the heart. One point I didn't bring up with the right coronary arteries, there are branches that go to the middle portion of the heart, where you remember the septum was located at, where the conducting network, the SA node, the AV node, the bundle branches, Purkinje fibers, and again, portions of this are fed by the right coronary artery. Inferior to the right coronary artery is the right coronary artery generally gives off marginal arteries, little branches that come off the main portion of the heart. These would be considered, if I can get my arrow to show, these would be considered little marginal arteries that feed off. These are the arteries that people refer to when they say, oh, I grew a new blood vessel so I didn't have to have bypass surgery done. These are the vessels that actually will hypertrophy and enlarge and compensate when these bigger vessels get obstructed chronically. Post-interventricular artery, the posterior descending artery, runs around the apex of the heart to the posterior interventricular sulcus, which is in the posterior aspect of the heart that you see posteriorly there. Posterior interventricular artery, blood supply to the septum and portions of the ventricle as well. Left coronary artery supplies blood to the left ventricle, left atrium, interventricular septum, reaches the anterior surface of the heart and gives rise to the circumflex branches. In the anterior interventricular branch, that's the left anterior descending anterior interventricular branch. The circumflex artery curves to the left. I'm sorry, I didn't realize your book called it a different name, but that's fine. The left interventricular artery. The circumflex artery curves to the left around the coronary sulcus and eventually meets and fuses with small branches of the right coronary artery. Again, this is dependent upon whether the person is left circumflex dominant or right circumflex dominant, but the little branches will meet, all of which will supply the posterior aspect of the heart. The larger anterior interventricular artery, left anterior descending artery, okay, it does use both names, swings around the pulmonary trunks and runs to the surface within the anterior interventricular sulcus. The anterior interventricular artery supplies small tributaries, continues with those of the posterior interventricular artery. The interconnections between the arteries are called arterial anastomosis, basically where vessels will join and jointly supply blood. The arteries are interconnected this way, and the blood supply to the cardiac muscles is relatively constant. There are some pressure fluctuations in right and coronary arteries when the heart contracts. Cardiac veins, there are great cardiac veins, begin on the anterior surface of the ventricles. Again, typically where you see the arteries, you're going to see the veins. The great cardiac veins reaches the level of the atrium and curves around the heart. Within the coronary sulcus, the veins empty into the coronary sinus that lies on the posterior portion of the coronary sulcus. There are other cardiac veins as well. Important to read that. I'm not testing you on these veins, but there's a posterior cardiac vein, middle cardiac vein, small cardiac vein, anterior cardiac vein, all of which take the used blood, the unoxygenated blood from the heart, gets back into the systemic circulation, where it gets back into the back into the vena cava and back into coronary circulation, where it goes to the pulmonary circuitry and becomes reoxygenated again. The concept of coronary artery disease refers to areas of partial or complete blockage in coronary circulation. You need to know this slide. Cardiac muscle cells need a constant supply of oxygen and nutrients. Reduction in blood flow to the heart muscle produces corresponding reduction in cardiac performance. Reduced circulation supply is known as coronary ischemia. You have to know that definition. Generally results in partial or complete blockage of the coronary arteries. The usual cause of the formation of fatty deposits are atherosclerotic plaques. These are plaques associated with thrombus. Again, the plaque only narrows the lumen. Once that lumen becomes narrow, small blood clots that pass through our vessels every day then get hung up. So it's the diameter of this lumen that causes the problem. This is, you can see, plaque accumulation that has occurred in this vessel. Just a little illustration demonstrating to you how plaque can eventually narrow the lumen. Now, the other thing that plaque does, just as you would see in a water pipe, you've got the same volume of fluid passing through, like in a water pipe, but if you narrow the lumen, the pressure gets higher inside the pipe. Coronary arteries are the same way. Now this blood vessel, not only is the lumen smaller, but it's also under greater pressure, increasing the risk of coronary aneurysm or rupture in that blood vessel, but most certainly it puts you at a very high risk of little small blood clots coming in and blocking this passageway. Anything distal to the blockage, you get a blockage in the left main coronary artery, anything distal to that goes without oxygen and will die. Heart muscles don't regenerate, don't have centrioles. You have a heart attack, that's it, the muscle's gone, heart doesn't work well anymore. Either you die or you become a cardiac cripple. So, important process to understand, anything distal to the point of obstruction, if a blood clot gets in there and blocks away, anything distal to that doesn't get oxygen, that dies. What can you treat this with? Spasms can occur as well in these vessels. Sorry, I jumped over that. Spasms can occur. Vasospasms, Prinzmetal angina is a condition where the vessels just spasm, shuts off circulation for a short period of time, then the spasms release and blood flow returns. But the person can have angina related to that. Visible plaque can be seen in an angiography where they actually inject contrast dye into the coronary arteries, which will allow visualization of those arteries, and then you can identify the area of obstruction. And I'll go into a little more detail about that in just a second. There's also one of the first symptoms of coronary artery disease is something referred to as angina pectoris. Most common form, temporary ischemia, develops when the workload of the heart increases. Ischemia. Now, the heart can have normally some ischemic changes. A person has hypertension and the heart's got to beat really, really hard, like my hand. My hand is a little bit ischemic. Now, the circulation in my hand is completely normal. It's just I'm putting it under enormous strain. The heart is the same way. You put the heart muscle under a lot of strain, pumping against a lot of pressure, you can develop ischemic patterns. And we see that a lot of times on diagnostic studies. Doesn't necessarily mean that the person has coronary artery disease. Could mean that they have hypertension and just the heart's under additional strain because of that. Angina can be treated surgically by opening up the stricture, reducing the workload of the heart. You can reduce the workload of the heart by putting a person on medications. A beta blocker slows down the heart rate, relaxes the smooth muscles that's inside the coronary arteries, and actually the heart won't beat as forcefully anymore. So there are some ways to be able to do this medically, but if the blockage is significant, you can use a catheter, small catheter, pass it to the point of the coronary arteries, insert it into the coronary arteries, inflate a balloon that will open up the area of obstruction. You basically are crushing the plaque and opening up the lumen and making it bigger. You can also use a laser to clean out the area, basically by the same principle as a roto-rooter or the balloon angioplasty as I referred to earlier. This is a balloon angioplastic procedure where basically there's the plaque, you insert the catheter with the balloon, you blow up the balloon, and you hopefully will be able to remove the plaque. Now in some cases that may not work, and when that occurs, you opened up the plaque, but then the vessel collapsed closed again. And so in those individuals, you have to put in a little stent. A stent is a metal wire that's basically inserted into the area of the plaque. The stent is a metal structure, an alloy, and when you blow up the balloon, that stent is over the balloon. So when you blow up the balloon, the stent has these little locks in it. So when it opens up, it stays open. And eventually, the individual's endothelial tissue will grow into the stent, and this stent will keep the vessel open. Now, the advantage to this, obviously, is that the person doesn't have to go through bypass surgery. Some disadvantages to this: this is a stent. It's metal, so platelets will stick to it. And so if platelets stick to this, it can actually cause an obstruction. And so most people who have stents placed go on blood thinners for a period of time, keeps the platelets from sticking together, reduces the clotting factor. So many people who have stents placed are on blood thinners, and maybe on blood thinners for a long period of time, or maybe on blood thinners for lifetime, depending on the severity of the coronary artery disease. Typically, you still do it with the balloon. The balloon is actually what puts this in its proper place. And the reason why they can be so specific, they're usually injecting dye at the same time. They inject a little bit of dye, they advance the catheter. They inject a little bit of dye, they advance the catheter until they're at the exact point where the obstruction is at. Then they blow up the balloon. Blowing up the balloon opens up the stent. When the stent's opened up, the locks fall into place on the stent and it stays open. Coronary artery bypass surgery can be done as well. Remember, coronary artery bypass surgery only is effective if the distal portion of the blood vessel is open. Now, what do I mean by that? Coronary artery bypass grafting, you got to have some place to bypass to. Remember, you're going around an obstruction. So let's say you have a blockage here where the arrow is at. Okay? This bypass goes around the blockage and it locks into, it attaches into this vessel. Now, what does that mean? The rest of the vessel has to be open. If you have an obstruction here, you have an obstruction here, and you have an obstruction here, and here, and here, and here. Bypass surgery can't help you. Why? Because there's no place to bypass to. Everything is blocked distal to the obstruction. So bypass surgery only works if you got some place to bypass to. Does that make sense? Okay. And you can do bypass surgery from anywhere. Most of the time they'll take it off the aorta. Now, you may hear of people who have veins that they use for transplant. Take a vein out of the leg, take the internal mammary vein out of the chest. You use that as the new coronary artery. Veins do have muscles. At first they're kind of floppy, they're kind of weak, but within a few weeks the muscles inside the vein, when you put it under pressure, it's like lifting weights. Those muscles become stronger and they will turn into very effective coronary arteries. Same principle exists though. If you attach a vein here as a bypass to pass a blockage here, you got to have open vessels distal to that. So the bypass goes from here to here. That's fine, but these vessels have to be open and working, and that's the only way bypass surgery would work. You can bypass a number of vessels. You can have a quadruple bypass. You've probably heard of those before, where people have 4 vessels that have to be bypassed, and that's fine as long as you got some place to bypass to and things work. And diabetics, what happens in diabetics is vessels start to occlude starting distally. In other words, diabetics suffer from in-vessel disease. At the end of the blood vessel, that's where it starts blocking off first, and then it progresses up. So a lot of diabetics aren't eligible for coronary artery surgery, coronary artery bypass surgery, because there's no place to bypass to. The vessels are blocked down here, and it's no place to reroute the blood to. So that's why the surgery doesn't